Okay, then I will welcome everybody to this ERS webinar, one of the series. And today we will talk about cystic fibrosis and primary ciliary dyskinesia. This first speaker is Lennart Hansson. He is working at a lung physician at Skåne University Hospital in Lund, Sweden. And please, after that, it will be Kasper Arnes, who will talk more from a perspective of an ENT surgeon about these diseases. During the session, you can write questions in the chat, and then we'll take the question after the two speakers. So please, Lennart, it's your turn to start talking.
So I'm just trying to get the share screen. So can you see this? Hopefully. I'm going to give you a short background on first cystic fibrosis and then primary ciliary dyskinesia. I start out with cystic fibrosis. I'm working daily with CF patient and lung transplant patients. First of all, why is it called cystic fibrosis? Well, the background is that the disease, which we call today cystic fibrosis, has been known as a clinical entity for about 100 years. But the doctors were aware that there was some kind of connection between the gastrointestinal tract, the upper and lower airways. So in the 30s, a Danish-American pediatric pathologist, whose name was Dorothy Anderson, she described and used the term cystic fibrosis for the first time in 1938. And in a title called Cystic Fibrosis of the Pancreas and its relation to celiac disease, a clinical and pathological study. And what she described was 49 children with meconiomelia, intestinal and respiratory problem, and very characteristic pathology of the pancreas, and why it's called the cystic fibrosis of the pancreas. But for a couple of decades, this diagnosis wasn't used because we used the word mucoviscidosis for a couple of decades, but in the 70s, 80s, it went back to cystic fibrosis. How common is cystic fibrosis? Well, it's considered to be the most common severe hereditary disease in the Western society. And the incidence varies very much depending on what part of the world you are. For instance, in Europe, the highest incidence is on Ireland, when it's almost 1 out of 1350. In the States, it's 1 out of 2,500. In Sweden, about 1 in 5,600. But it's much less common, for instance, in Finland. In Asia, it's much less common, also in Afro-Americans. And the true incidence probably will be calculated when newborn screening is introduced, which is in many countries. It's Norway and Denmark, but not in Sweden. There's no difference between male and female. From being a pediatric disease, it's now an adult disease. So the median age for patients in Europe is 20.9 years, and the highest median age is Norway, which has 26 years. Denmark and Sweden is similar. The lowest are all the one in former Eastern Europe. What about the genetic? Well, it's an autosomal recessive disease, which means that you have to have two parents that are carriers to get the disease. And for instance, in Sweden, 2 to 3% of the population are carriers. On islands, almost 1 out of 20. It's well known where it's caused. It's caused by a defect on chromosome 7 that produces something called the CFTR, and the CFTR is the cystic fibrosis transmembrane conductance regulator. It's been very well described for about 30 years. And it's an ion channel that transports chloride ions out of the cells and is defect in different ways. It causes changes on the chloride excretion and also affects sodium and sodium bicarbonate. The problem is less water and a very thick sputum, but is created in the airways. As I said, the CFTR was discovered in 1989, and there are about 2,000 different mutations described. Of these, there are about 350 related to CF. And the most common mutation in Europe is F508del, which is about 40% of in Europe are homozygote, another 41 are heterozygote, and about 1/5 of all have completely different mutations. When we describe those different mutations, you can divide them into different classes. So far, we have 6. It could even be 7. And we usually consider the class 1 to 3 to be a more severe disease, which causes no synthesis at all of the CFTR, or it's blocking process, or it's blocking regulation. And 3, 4 to 6 have a milder disease, but it's not completely true. Because this is very, very heterogeneous disease with a very wide variation in severity and symptom. And it all, in families with 3 or 4 siblings, one can be almost healthy and one can be very sick and be transplanted at the age of 15. And it also affects one or many organs. It's also different. And there is a quite bad correlation between the mutation and the lung function. So you can be 15 years of age and have a very severe disease and be homozygote for F508del, but you can be 55 and have a quite mild disease. But we can say that all patients usually have a progressive disease. As I said, it's been changed from being a pediatric to an adult disease, and today's expected survival is probably more than 50 years. What about diagnosis? As I said, when you introduce newborn screening, it's going to be much more easier to define the disease. But in average, most children most patients are diagnosed before the age of 1. But there are some people that probably never going to be diagnosed, especially have a very mild disease. So the oldest patient we diagnosed in Sweden was 73 years. So what organs are affected? It depends on how much effect there is on the CFTR. A number of different organs can be affected. From upper airways, that is the sinuses, with infections, inflammation, polyps in the nose, causes symptoms like the headache. Then we have from the lower airways, bronchial wall thickening, effect on the biofilm, thick sputum, causes infections, colonizations of different bacteria. And then developing of bronchiectasis with fibrosis, and of course, effect on lung function, and gradually developing a COPD functionally. Pancreas, as I already described before, there is a lack of enzymes, and it causes a defect uptake of fat, and about 1/4 of all patients get a CF-related diabetes, which increased over age. Also effect on the gallbladder and the liver. Some patients are affected already in a teenager, where you can get the cirrhosis and can lead to a liver transplant. If the liver is affected, it's usually at the younger age, but you can have effect of the also when you're getting older. A major organ that is affected is the stomach. It can be pain, of course, all the uptake defects, and it's also a constant problem of having a diarrhea or obstipation. This was an extremely large problem before the introduction on the supplementary enzymes. A problem that could occur in quite a lot of patients is what's called the DIOS, the distal intestinal obstructive syndrome, which is a pain often in the right lower part of the stomach, mimicking appendicitis. And if patients live for a long time, there's a risk of malignancy, especially from the colon. Effects on joints and skeleton, that is pain, not arthritis, because they are never swollen. And of course, osteoporosis and fractures. And we can say that almost all men are infertile. They have a congenital absence of vas deferens, and there is a lowered fertility in women. Then there is effect on other for instance, pharmacological and pharmacokinetic effects. So they have a completely different metabolism. They always need higher doses of antibiotics, usually twice the dose as a normal, and they also tolerate for instance, opiates much more than others. So what's the problem? What's a major problem? It's often the lungs. Uh, Almost all patients, when they grow older, develop more or less symptoms from the lungs. And as I described, the effects of mucociliary clearance, the inflammation, the phlegm, and the mucus plugging. And most patients die from lung complications. Nowadays, you can say there are few patients that actually die from lung complications immediately, because the majority of those patients are transplanted, and they will finally die in complication to the transplant, that is a chronic rejection. Of course, problem is the bacterial infections and colonization. They usually start out with Staphylococcus aureus and end up with Pseudomonas aeruginosa, fungi, mycobacterium, or nowadays it's common with non-tuberculosis mycobacterium. A symptom that was quite common previously was hemoptysis and pneumothorax, and they are quite rare nowadays. If we look at the bacteria over time, this is a description on what happened. Most pediatric patients have Staphylococcus aureus, and then gradually over time they develop Pseudomonas aeruginosa. And some have a very tricky bacteria called the Burkholderia symposia. It's considered to be more severe, but they can have all gram-negatives: E. coli, Klebsiella, Serratia, Stenotrophoid maltophilia, and a lot of other bacteria. Keeping up with lung function is extremely important. It's quite unusual to have complications if you have a normal lung function. And it's important to keep the lung function as good as possible. There is no exact limit, because you can have quite a lot of symptoms having a quite normal, not normal, but a pretty good lung function, and you can be quite healthy even having a quite bad lung function. But we evaluate the lung function very often and try to keep them as high as possible, and at least keep them as stable as possible. Bronchiectasis are common, and the one on the right side here is very, very typical for CF patients. They are in the upper part of the lungs, and those are more evenly distributed. Those, of course, exist, and you can have it in the lower, but it's quite rare. This is a bronchiectasis on a CT, where it's very, very typical. Those are lungs from one of our transplanted CF patient. It was a female CF patient, was transferred 12 years ago. She's now feeling very well. And this one is a right lung from another female CF patient we transplanted 4 years ago. There was no function at all on the right one. She is now having a completely normal life with a normal lung function. So how do you diagnose cystic fibrosis? Well, it's based on the suspicion of CF, that is, odd bacteria, symptoms from a young age, upper airways, lower airways, gastrointestinal problems, and deteriorating lung function, and of course radiology. And if you find bronchiectasis, you have a high grade of suspicion. We still have a quite old-fashioned diagnostic, that is sweat tests, and they are usually positive. If you have several normal, it's unlikely to have cystic fibrosis, but we need genetics, that is, to verify the different mutations. So how do you treat cystic fibrosis? Well, there is no curative treatment, and I personally do not believe that gene therapy as such is going to have any part in this one. One of the most important things is to be treated as a specialized CF center. In Sweden, we have 4, Denmark have 2, Norway have 1, and the most countries in Europe have several CF centers in each country, because they're quite large. Important is physiotherapy, that is inhalations, isotonic or hypertonic saline, pulmozyme, and very important is daily physical training, running, jogging, physiotherapy, etc., etc. The pharmacological therapy is, of course, important, but it's not very important, for instance, using bronchodilator, inhaled steroids, but in antibiotics, it's extremely important. It can be oral, it can be intravenously, it can be inhaled, or installation in nose, or it can be combination. Some have continuous treatment with oral or intermittent treatment when inhaled antibiotics. What has developed over the last 5-10 years are new therapies that affects the CFTR. It's called Orkambi, Trikafta, or others. And they have changed the stage extremely much over the last years, especially when the triple combination was introduced a couple of years ago. And they improve in lung function, in weight, etc. And it could be possible that in the future, a child is treated with CFTR modulators at the age of 6 months or even earlier and could possibly live a completely normal life. How much is going to be affected, time has to tell. Of course, nutrition and enzymes are important. And then, of course, if you have problem with the sinus, you have to do certain treatments, and Carsten's coming back to that. And lung transplant is quite possible. About 1/5 of all CF patients is going to be transplanted over life. And of course, it's a lifetime treatment. Now I'm going over to primary ciliary dyskinesia, which is very, very similar to CF in the clinic, but it's a much, much more complex disease. This is what it's about, the cilia. So we talk about a disease that is called ciliopathy, which is a group of diseases that affect the mobility of the cilia. They are all hereditary, and they cause a defect of the cilia. And in some cases, they are part of other genetic disorders. They are quite few. I mean, they are numerous, but they are still uncommon, and PCD is one of them. Those are other ciliopathies. For instance, Usher syndrome goes with blindness and deafness. We have as many as Usher syndrome patients in Sweden as we have PCD patients. Alston syndrome is quite rare, very similar to Usher's, described in 900 patients in the world. And this one, orofacial digital syndrome, is very uncommon, been described in Bedouins from Kuwait and in Newfoundland. Then just to mention that you can have a secondary ciliary dyskinesia, and it's acquired due to external factors like infections, bronchitis, smoking. They're much more selective. They're not as they're quite different, and the symptom can go back spontaneous, or for instance by treating infections or smoke cessations. Okay, going back to the cilia. In the cilia, there is a dyne in arms, and those are the one there where the energy in the ATP is converted into movements. And a lot of those diseases or the mutations that affected PCD are originating from the development of the dyne in arms. It's similar like the CF. It is an autosomal recessive disease. It's caused by mutation that, so to say, creates the structure and the function of the cilia, but it's much more complex than, for instance, for CF. It's not that many mutations are found so far, but they are spread on many more chromosomes. And so far, about 2/3 of all patients could be diagnosed based on some kind of mutation. Some of them are more common, like the DNA-H5, but it's almost 1/4 or to 1/3. But the other ones are much more uncommon. And there are different variants of the defects. PCD once upon a time was called immotile cilia, and it didn't move at all, but that's just one of different variants. Then you have a dyskinetic cilia, which means that it's very ineffective with slow mobility, and it could be aplastic, which is undeveloped, and then it's defect in the structure. But the problem altogether, it doesn't work in a normal way. Well, how common is PCD? Well, that is a problem. We don't know, because the exact incidence is completely unknown. It's estimated to be someone between 3 to 10 over 100,000. And theoretically, we would have the same amount of CF patients in Sweden as we have, let's say, the amount of PCD patients as we CF patients. But it's definitely not true. We have too few patients diagnosed, and it's probably because it's much more complex both for diagnose and for disease in the clinic. And it's same thing for cystic fibrosis as is PCD as for cystic fibrosis. There's a bad correlation between genotype and phenotype, and no difference in gender either. One syndrome, or what is related to PCD, is what we call Situs inversus, which is a rotation of the organs in the inner body. And you can have a complete Situs inversus, which means everything is rotated. You can have it partially. Why do they rotate? Well, it's because during the embryogenesis, you need motile cilia to have a correct rotation. And if you don't have that, the rotation is going to be at random, which means when the rotation occurs at week 8, 50% will go turn right and 50% turn left. But that is not true in the clinic because we have too few Situs inversus. Only 1 out of 5, 6 among our patients have a Situs inversus. Common syndrome is what you call the Cotagno syndrome, which was named by Swiss doctors in the 1930s, which is a combination of Situs inversus and PCD. And you can also have Situs inversus without PCD. Well, what about the symptom? As I said, it's like CF, it's very heterogeneous. It can have mild symptoms and it can have severe symptoms. But here it's only from the upper and the lower airways. It's very rarely diagnosed at birth unless you have a Situs inversus, and it's quite often missed because it could be misinterpreted as asthma for the lower airways, and a lot of children have problems with otitis and otosophagitis, and the effect of hearing probably affects a lot of other children as well. Then gradually they have chronic sputum production and chronic rhinosinusitis, and then from the low airways they are similar as the CF. They get the bronchiectasis. They have the same kind of bacteria, Staph aureus, Pseudomonas, non-tuberculosis mycobacteria, etc. And over adolescence, they have more infection from the upper and lower airways, polyps, headaches, perhaps less otitis when they're getting older. And gradually, when they grow up, they have problem with the reproduction organ, and so men are infertile because they don't have any mobility of the sperm because of the defect cilia, and they have a low sperm quality. But women have a reduced fertility, and then also the same effect of the cilia and the fallopian tube, about 50% reduction. Here are the bronchiectasis as well. Well, how about diagnostics? Well, one of the problem is that it's hard to see what patient should we suspect have a PCD. A lot of patients are probably undiagnosed, especially in their younger age, and because there are so many pediatric patients that have problem with their ears and their noses. But when you gradually find uncommon bacteria, when you get Pseudomonas, when you get gram negatives that usually don't occur in upper and lower airways, you could suspect PCD or CF. There is no gold standard, there is no simple method for diagnosis. The most common one is use the nasal nitric oxide, NO. It means those values are low, and you can have biopsies or nasal mucosal brush samples. From those, you can use them for high-speed video microscopy analysis, looking for the mobility, frequency, and coordination. And you can also have transmission electron microscope. But you can see that it could be normal and it could change over time. Using transport time it's not a very solid method and it's not standardized very well. And which method is used probably depends on the tradition where you come from and what diagnostic you have can use. And of course, the genetic test can be used, but it's quite expensive. We don't use it. We don't have it in Sweden. We used to send it to Germany and now to Denmark. This is an algorithm which I'm not going to go through, but this is one that is used or developed by the ERS, not the European Rhinology, what is this European Respiratory Society Task Force in 1720. And as I said, depending on the clinical symptoms, NO, nasal brush, and I'm not going to through it, I'm just going to refer to it, and it's a very good article on diagnosis. Now, finally, what about treatment? But it's very, very similar to CF. There is no cure, it's physiotherapy, inhalations, and same as cystic fibrosis. Training, pharmacological treatment in a similar way with antibiotics. Surgery was quite common in the 80s and 90s because they did lobectomies, especially for the middle lobe, and it's quite rare now, though. And of course, your part of it, the ENT sinus surgery, which Carsten is coming back to. And lung transplantation is extremely rare. It has been done, but it's very uncommon. Of course, it's a long time treatment. So what about prognosis? Well, it's usually considered to be good. And in the literature, it says that most patients have a normal active life and normal lifespan. It is probably both true and untrue because there are definitely patients that are going to have a lot of clinical problems and a lot of infection, and it's going to affect their quality of life a lot, but not necessarily the lifespan. And lung function deteriorate over time, but much more slowly than CF. And in general, you can say PCD and CF are very similar disease, treated in the clinic about the same way. And it's not uncommon that we end up with a syndrome that is very similar to PCD and CF. That is, they have problems from the upper and lower airways, and we still do not get a really 100% diagnosis. But in a way, it doesn't matter. We treat them in the clinical similar way. Thank you very much.
Okay, thank you very much, Lena, for that speak. If you have any question, just please write it in the chat, and we take them after Caspar Arnes, who works at the Rigshospitalet in Copenhagen, who will talk more about the nose and the treatment in cystic fibrosis and primary ciliary dyskinesia. Please, Caspar. You have to unmute yourself. Caspar, unmute you.
Can you hear me now?
Now we can hear you, yes.
Okay, thank you so much.
Beginning. Please, welcome.
Yes. So yeah, I'm a rhinologist, and would like to tell you something about how we treat our CF and PCD patients in Copenhagen. So that's from a rhinology point of view. And as Leonard has beautifully told us, both of the diseases have a genetic default, but the CF patients have very thick and sticky mucus, which gives them a compromised mucociliary clearance, where the PCD patients, this is a normal ciliary flow, but in decreased or totally not present ciliary flow. Both of the diseases makes the mucus stay and make them postponed or disposable for bacteria infection, and especially gram-negative bacteria. And this is a picture of a Pseudomonas. Both the PCD and the CF patients are actually patients having a normal life and are actually often a good quality of life, but they often have symptoms of rhinosinusitis. These are actually, as you may know them, it's obstruction, it's nasal discharge, especially pressure, headache, loss of smell. But what is very special for these two groups is that they will nearly never tell you about these symptoms if you don't ask them. Besides the classic CRS symptoms, these patients also have our post-nasal drip. And from the sinuses, we know that both mucus and bacteria go all the time from the sinuses down to the lungs. And if they have an infection there, they can either maintain it or restart the infection in the lungs from the sinuses. The reason is that the sinuses have a very good environment for bacterial infection. We can see and have shown that they are biofilms here. They have a bit of a different immune response compared with the nose. So there's a lot of IgA. There is low tension of oxygen and very low number of neutrophils, the PMNs, which altogether makes a perfect growth for gram-negative bacteria as Pseudomonas. So they sit up there in the sinuses and become more and more resistant. These are some, actually all of the kind of bacteria that we have found in the sinuses during sinus surgery, and all the red ones are the most dangerous ones, and in top is a Pseudomonas, and number 3 is the Burkholderia, which Leonard showed us. It was not so common, but again, a very dangerous kind of bacteria. And all these are, as I told you, found in the sinuses and can go down into the lungs from time to time. So when we see the patient at the first time, often referred from the pediatric or the CF department, then the first question is always, does these symptoms come from the sinuses? And then you have to remember that they are not rhinologists. So headache, what kind of headache is sinusitis? You can often help by just the normal questions that we do. And then you have, of course, to ask them what treatment has been done up till now. As in normal rhinosinusitis, nasal irrigations with saline has a very high level of evidence, and especially in CF patients. And some studies show that there is an addictive effect, a super additive effect by adding salt water or extra salt, so it gets hypertonic. You can also add Dornase alpha into the saline, which makes the very thick and sticky mucus more liquid. Using steroids has been very debatable because the polyps and the inflammation in the nose is not type 2 inflammation in general. However, some patients has been reported, and also some patients that I have swear that they have an effect of using nasal steroids and oral steroids on the nasal symptoms, but it's not something that I use in general. This is, of course, the CT scanning with a large cross, because to start off with, the lung medicine, the pulmonologists, they would like to take CT scans and show us them, but that never give us any clue on if they have symptoms from the sinuses or they have bacteria, because they nearly all have to some extent, have opacified sinuses. However, when you do surgery, we always need a CT scan, because we know that they have aplasia of the sinuses. Sometimes they're, in general, the anatomy can be different and challenging. The next question the patient will ask is surgery needed, doctor? And then you would like to ask again the patient, what are your expectations? Do you hope that we by surgery can remove the bacteria from your nose and your lungs? Or do you have an expectation of the symptoms to improve, or both? That's very important to ask both either the question or either the patient or the pulmonologist what the expectations are. It's very difficult to actually know if you have an early colonization with gram-negative bacteria within the sinuses, but we can try to do a culture from the middle meatus and the nasopharynx. You can also try to take blood tests for antibodies, but in general, it's actually difficult to know if you have 1 or 2 small pseudomonases being within one of the sinuses. However, it's difficult. We do a lot of sinus surgery. And when doing it, we always start with doing a quick bronchoscopy to help the pulmonologist to get some good material from the lungs to culture and know the exact status of bacteria and viruses and so on in the lungs. But besides that, we actually do a normal sinus surgery. It's not so difficult. It's different actually from what you normally do when you do a polyp sinus surgery. But what is important is that you do address all sinuses. When the most of the studies published concern the maxillary sinuses, but you can as well have symptoms as well as bacteria from the, for example, the frontal sinus or the ethmoid and sphenoid as well. Here it is, we believe, important to make large ostial diameters so that they are accessible for post-operatively cleansing, flushing, and antibiotic treatment. This is, I hope, is a video from Brad Woodworth in Alabama, who also do sinus surgery. And you can see this is the sticky mucus, which to start off with seems as if it's clean, but you know that the mucus is within the mucosa, and there's actually mucosal abscesses. So when doing the surgery, it's actually, we believe, important to be a bit more aggressive and a little less mucosa sparing than we used to do when doing sinus surgery. We do, as I told you, a lot of sinus surgeries, and we made a study showing that 1/3 needs a revision surgery after at least once within 30 years. Nevertheless, the patients, they return again and again and ask for surgery. We made a study looking at more than 100 CF patients and could see that the sinonasal symptoms, they improved within 12 months, and the quality of life also significantly raised 6 months after surgery, again giving us a good reason for doing these surgery in the patients. That was the symptoms, but what the patients think is more important is the lung infection and the lung function, the lung status. And we looked at 61 patients who what we call were intermittently colonized, meaning that less than 50% of the sputum samples were positive for some kind of gram-negative bacteria. And 1 year after, 22 of these patients had not even one positive culture from the lungs, and they do at least one culture a month, so that's at least 12 cultures which was negative, which were positive with the gram-negative bacteria before surgery. And we tried to follow these patients in 3 years, after surgery, and this takes a little explanation, but you can see down here is the middle group is again the intermittently colonized, and only about 25% become this little gray box up here, were the patients who become chronically infected. And again, a lot of patients, nearly 25%, didn't have any bacteria from the lungs after sinus surgery. So this is the big question: when should you do sinus surgery? We try to figure out when there are bacteria in the lungs, in the sinuses, and we try to look at the lung function. If that decreases, we try to measure antibodies against, for example, Pseudomonas. We try to culture to see if there should be any positive cultures from the nose. And again, if we have, that's wrong. If they have had a lung transplant, then they would also like to get the bacteria removed from the sinuses. Number 5 here, that should be CRS symptoms. should be standing for itself, because that's not something to do with infection. So if there are severe symptoms, do the sinus surgery. So it should be some kind of collaboration between the rhinologist and the pulmonologist to decide together with the patients when the sinus surgery should be done. When we do the surgery, we try to intraoperatively flush the sinuses with saline and antibiotics. We give them IV antibiotics as well after surgery. And we do the irrigations where we mix the saline with some kind of antibiotics, often promyxine. And we, of course, do the cleansing as we normally do. We made a study to try to evaluate the flushing. And the reason why we do the flushing is that we would like to transfer the treatment strategy from the lungs, where we need some kind of a local treatment, to the sinuses. So we made patients flush with some kind of illuminating fluid, and we could see that unfortunately there was room for improvement, that the fluid didn't stay for very long in the sinuses, but only in the nasal cavity. So we just made a study where we tried to take some fibrin, the patient's fibrin, and mix it with antibiotics. I'll just show you a little video here where we applicate it into the sinuses. You can see that we spray it in this maxillary sinus. So this is fibrin from the patient mixed up with the antibiotics, and you can see it's a kind of dusty. We could measure that the antibiotic was still present at least a week after the surgery. So hopefully this will be the way to go in the future. So, yes, just the final two slides. Leonard, he mentioned the new treatments, the CFTR modulators. And this is my former patient, where to see his lung function. You can see here is stable low. Here then he got this, it's called Trikafta, and the lung function has been quite improved after that. There's made a couple of studies examining whether these CFTR modulators, they also affect the sinus symptoms, and there's no doubt that they actually do. And that's what I hear from all the patients. This study has measured the SNOT-22 and seen an improvement. And there's no doubt that this, what was before thick, sticky mucus, now transformed to very watery and runny nose. So some patients now, though improved, complain about runny nose instead of being stuffed. So just the take-home message: ask the patients, the CF patients, if they have any symptoms, as well as the PCD patients, if they are severe PCD patients, and then do sinus surgery if they have symptoms. Do the culture, and if you suspect any kind of infection, then again, that will be a point to do sinus surgery and topical treatment. So that was my lecture. Thank you.
Thank you, Kasper, very much for that. And we do have some time for some questions. And we have one question from the audience here who asking, why are there anaplasia of the sinuses? And why doesn't they have any frontal sinuses? Kasper.
Yeah, the question is that we don't know for sure. The theory is it's because the early sinus infection keeps them from developing, and actually it's a myth that they don't have sinuses. Some of them have frontal sinuses as well, but again, the infection, it could be the reason. And we can also see that there is new bone formation, and yeah, it looks sometimes like osteitis when you look at the CT scan. But the answer is that we don't actually know.
Are there a lower age? You're talking about operation on cystic fibrosis and maybe PCD children. But are there any lower age that you shouldn't operate on? Do you have a lower limit for that?
No. When you look at the EPOS, then generally in doing sinus surgery, there's no lower age, but we would like them to be able to cooperate, to do nasal cleansing afterwards, to do the sinus irrigations. So we have had some patients around 6-7 years, but that's actually our lower age. But there is no reason besides them being capable of completing the post-operative treatment.
Okay. And for Lennart, you talked about something neonatal screening. Why shouldn't we do neonatal screening, or why don't we have it?
Well, it's very odd. Most countries in Europe do have newborn screening. Denmark has, Norway has it, and in Sweden it has not been accepted due to ethical reasons. And I think we should have newborn screening, and I think we must have it because it's much easier to handle the diagnosis. But the idea is that if you could be diagnosed for a very mild disease at a very young age. For instance, you could have, there are those mutations that are extremely mild and might only cause infertility at the age of 30. They are going to have no symptoms at all. And then they are going to live with the burden of a quote life-threatening disease. But in Sweden, we still haven't settled that. Norway, Denmark, they have newborn screening and they have much more experience of it. But on the other hand, it is a little bit tricky to handle those with mild disease. And I know, for instance, in some countries, the patients are not informed about that. And that is, you can discuss this from an ethical point of view, if that is correct. But on the other hand, it would be extremely good to have the newborn screening because it's so simple to do. It's just to apply it.
Okay. And Casper, you mentioned it's something about lung transplantation and sinus surgery. Do you always do that sinus surgery before lung transplantation or after, or what do you say about that?
We're actually discussing it with the lung transplant doctors, and we often make them do the decision. They would like them to be having surgery within the first couple of months, and that's why what we try to do. There's been a study down in Switzerland who has shown very good results doing the sinus surgery and improving the outcome. So when they are on the waiting list, we evaluate them to see if they have any sinus symptoms, and also do the CT scan to be prepared. So we don't do it the same day or the same days that they had the lung transplant, but try to do it as quick after as the anesthesia allows us to do it. But in all
after lung transplantation, you don't do it before lung transplantation.
No. And yeah, you can discuss. The problem is that we never know when the lungs will come. So if you do the sinus surgery a long time before the transplant comes, then definitely the sinuses will recolonate from the lungs with the bacteria that will definitely be down there.
Which antibiotic do you spray into the sinus with farbine?
We have tried with both tobramycin and then a combination with a ciprofloxacin and promyxin or colistin. So you can combine the three antibiotics if you want to.
And then we also have a question about do you see any potential indication for new biologicals in the treatment of nasal polyposis in CF patients? Metosumab, dupilumab.
I don't know, to be honest. Not that I haven't heard of anything, to be honest, but I'm actually haven't heard anything, so I have to get back to that question.
Yeah, but it's
So
not a Th2. It's not a Th2 inflammation anyway.
Yeah,
shouldn't be any point.
Definitely no. What the new biologic treatments which helps the nasal polyps in normal CRS patients, I don't think that they will help the CF patients. Is that the question?
Do you do lavage of sinus with budesonide silent flashes afterwards? With budesonide steroid?
No, we don't.
Ever.
And again, that's the question. Again, if the steroids even work in CF patients, and we would rather they concentrate on putting some kind of antibiotics in the nose if we don't do the fibrin delivery.
And there was a lot about the surgery here. Questions. Is there a change in the age, in the extent of a sinus disease? I mean, do you do a bigger operation if they are older or smaller if they're younger? Do you think there's any different?
This could be a lot of could be very debatable. And I know that some advocate for doing more extensive surgery even the first time when they have surgery. But we actually, to start off with, only do, let's say a little sinus surgery, a little fist, but again, remember to open all the sinuses, and then if they come back, if the symptoms return, then you could do more extensive surgery like the middle maxillectomy, as the video showed, or a draft 2B to the sinuses.
And when do you, as a lung physician, Lennart, think that you have the need of us as ENT surgeon or ENT doctors, maybe, as you said?
Well, it's usually based on symptom, because I mean the patient's most problems, the symptom that causes most problem is headache. I mean, they are not very often, I would mean by it, they're not very concerned what bacteria they have in their upper airways or even their lower airways, but they are concerned about the feeling of being infected in the upper airways and have a very big headache, because that's what troubles them a lot before or after lung transplant, for instance. So that is probably the most common reason why I refer the patients to you.
And how often?
If I may add, then I think it's important for the ENTs to remember that the pulmonologists are not ENTs. So help them do what we do best, ask for the symptoms and try to evaluate and guess if this headache has anything to do with the sinuses, or is it tension or migraine or anything else. That should be what we do best.
And how often do you think, Casper, a CF patient or PCD patient should see an ENT doctor? Just once in lifetime, once a month, once a year, or only with some symptoms? We
have made the agreement that the pulmonologist only refers them if there's any kind of problem. But we have also educated our pulmonologists very well. So we are very confident that they refer when the patient have any kind of problem, which could be sinus related. If you don't have this good collaboration, then you could argue that they should be seen once a year, or maybe every second year, but they should, by time to time, have an ENT evaluation. That's in my opinion. And when the PCD patients in concern to them, they also could have ear problems. So they will more often maybe be in need of an ENT evaluation.
I think it's quite often, if I should say that they maybe forgot if you have a lot of lung problems, we quite often forgot about the sinuses. And that's why it could be quite good sometimes to see an ENT specialist, I would say.
But you have to
we have actually had quite a few patients when we did the research who actually scored around 0 in headache and 0 in obstructions. And when we then did the surgery, then afterwards they came and told us that they were feeling a lot better. So they were not aware of how the symptom, how it was supposed to feel not having headache. And that doesn't actually show when you do that kind of study, because you can't go below 0. But they're not aware always that they have the symptoms.
You were going to say something, Lennart.
Yes, I said that. Yes, of all the CF patients that are, there is usually the same patients coming back with the same symptoms. I mean, we have CF patients that never have any problems from the sinuses at all, and it's always the same patients with the same symptoms over and over again. I should know, have a figure about how many, but I really can't say if it's 10% or 15% or 20%. I mean, you could probably answer that, Cecilia, because you know how many of our patients you see.
And last for you, Caspar, do you see any disadvantage or any risk with doing sinus surgery on PCD CF patients?
There's been studies showing that it's safe just in the same way that sinus surgery is in other patients. So of course, you should never do surgery if there's not a reason for it, but it's not something that we think a lot about. We haven't had any major side effects or failure of surgery.
Okay. I think we have gone through quite a lot of questions. I have some extra questions too. And do we have any last words? Just get it as take-home message to the participant, Lennart?
Well, as I said in my final conclusion, that PCD and CF patients are very similar in the clinic, and it's the symptoms that we're going to treat based on the findings on the bacteria or the symptoms from the upper and the lower airways, and they are very similar.
And you, Caspar, last comment?
Treat the sinuses.
Okay.
I can also add that we have patients in our CF center they are CF PCD like, but we can't get the final diagnosis from those, and we just call them CF like patients. But we treat them in a similar way because they have the same problems.
Okay. Are they incompetent?
Oh, they have. We have looked at that as well.
Okay, thank you very much. Don't forget the sinuses if you have CF and PCD. And have a nice evening, and see you on next webinar in 2 weeks. Thank you.
Okay, thank you.